Okay. Hello, everyone. It's evening here. I'm in Delhi, India. Welcome to the 69 CSW NGO Forum and Dawn's parallel event on feminist intersectional perspectives during the COVID-19 pandemic, lessons learned from Asia, Africa, and Latin America. I'm Vanita Nayak Mukherjee. I'm a feminist activist and researcher based here in India. I'm Dawn's executive committee member, and I work on sexual and reproductive health and rights and co lead the Feminists for a People's Vaccine campaign. You will see my detailed bio in the chat for those interested. So, 5 years ago, in March 2020, Dr. Tedros declared COVID 19 as a global pandemic. That same year, 7 months later, Dawn launched a campaign called the Feminists for a People's Vaccine Campaign, or the FPV campaign in short. As we grapple with the countless long term impacts of COVID, it is time to reflect on some of the challenges, questions, and issues we have confronted during the pandemic. In Dawn, one of our key questions was, and still remains, why should feminists care about access to medicines? As Dawn pointed out 5 years ago, responses to the pandemic by our states were largely gender blind. We were caught short by the COVID 19 pandemic on many fronts, not the least in terms of feminist analysis and mobilizing for action and advocacy for access to medicines, vaccines, and treatments. To address this gap and to engage feminists to think through some of the challenging issues that confronted us, we highlighted the complex political economy informing access to medicines, vaccines, and treatments, the corporate power and interests, technology, law and human rights, the weak health systems, and the huge failures of governance. We focused on global and local inequalities, including the persistent gender face of inequality that was laid bare during the pandemic. Our researchers and speakers here looked at some of these issues from the vantage point of marginalized groups who were the worst affected. They documented and analyzed the experiences of some of these groups during the pandemic and have come up with some recommendations as a part of the regional overview. The FPV campaign used an analytical framework called the EDI, or the Equality, Diversity, and Inclusion, to explore ways in which healthcare and systems can be made diverse and inclusive. In this event at CSW69, we bring 3 of our 7 researchers and activists from Asia, Africa, and Latin America who will be highlighting the analysis and some of the findings from their regions. Before we begin, some housekeeping for those who joined in late. Please introduce yourself in the chat, name, country, and organization for those who have not done already. We are recording this session. Please keep your microphones muted. You're encouraged to use the chat box for your comments and reflections. We will have some time for questions and discussion in the end. Please put your questions in this Q&A box and not the chat box. It will help us to sift the questions more efficiently. You can use our hash. Lastly, we request you to cooperate and create a safe space for all present here. Please respect the people and proceedings in this room. Now, I will call upon the 3 speakers, and I have the pleasure to introduce our speakers today, Manuela Donato from Brazil, Tasneem Azim from Bangladesh, and Leah Arienu from Uganda. So I'm going to introduce them briefly, and Leda will be putting up their bios in the chat. Manuela, or Manu as we call her, has 15 years of experience as a feminist researcher and a committed human rights activist based in Brazil. Manu has a collection of degrees, a PhD in sociology, a master's degree in political science, and an international relations and graduate specialization in gender development and public policy. Welcome, Manu. Tasneem Azim is a public health specialist from Bangladesh and comes with 40 years of experience. Tasneem is a medical doctor and holds a PhD in immunology and virology and is now active as a women's health and rights activist in the feminist organization Nari Pokho in Bangladesh. Leah, welcome Tasneem. And Leah, our third speaker, Leah Arienu, I'm sorry, I always mix up I roll my tongue a lot, is a feminist advocate and expert from Uganda working on feminist political economy. She is specialized in public finance, labor rights, and reproductive justice. Leah has over 10 years of experience working on women's rights and gender justice issues across Africa. So, to begin with, I'm going to call upon you, Manuela or Manu. What were some of the challenges that women and other marginalized groups faced in your region during the COVID-19 pandemic? And how did the state respond to these challenges? So, Manu, over to you.
Okay, thank you, Vanita. Thank you all for being with us today. Thank you, Dawn, for this opportunity for us to discuss and think together of this scenario and the impacts of the COVID pandemic and what we have been able to learn from this experience from the past 5 years. So looking into the scenario of South America, there are two main points that I would highlight, and that I think it's important to understand how women and other marginalized groups were particularly affected in the region. And the first one is the interaction between the existing inequalities and the notion of exceptionality of the pandemic. In South America, the historical inequalities of class, race, ethnicity, and gender heavily marks how power relations operate. But those inequalities were not properly addressed in most of the policies that were part of the response to the COVID pandemic. Instead, the exceptionality of the context was used as political justification to adopt measures that deepen those inequalities. The responses were focused on the exceptionality of the context rather than in the inequalities generating the huge impact in the region. The measures of prevention through isolation were not an option for most of the population in a region that is strongly marked by informality and without adequate social policies. Domestic workers risked their lives going to work to take care of other families, while their own families didn't have the right to isolate, to access the internet, to work from home, and in many cases, even access water in their homes. It is important to highlight that when we talk about domestic workers, we are mainly talking about women, and in many countries, mainly Black women. And at the same time that the social isolation policies were guaranteeing the protection of some people, it was also generating more risks to other people. It is the case of women and girls who live in situations of domestic violence in their homes. It is the case of trans women who lived in countries that adopted circulation measures based on gender, like in Peru, where the law that was known as Pico y Género generated new vulnerabilities and situations of violence to trans people in a country where there is no legal recognition of self-perceived gender identity. It is the case of millions of Venezuelan refugees in the continent, including indigenous people, LGBTQI people, and sex workers, who were already facing precarious conditions of living and denial of their rights to health in many countries based on a restrictive conception and colonial notion of citizenship. In many countries in the region, as in Brazil, the groups in power took advantage of the context of emergency, of the attention focused on the pandemic, to advance legislation and regressive policies against human rights. Instead of strengthening health systems, science was questioned, false information was disseminated with impact during and beyond the pandemic. And this is the second point that I would like to highlight, is how women's sexual and reproductive health and rights were particularly attacked during the pandemic, not only because of the overburden of the health systems, but also as part of a strategy from ultra-conservative groups in power. Despite the recognition by various international organizations and reproductive health service as essential health services, including a call from the Inter-American Commission on Human Rights for states to maintain their operation in the countries of the region, what was observed was a significant regression in the guarantee of sexual and reproductive rights of girls and women. The majority of the countries experienced interruptions in reproductive planning and contraception services. And among the countries where these services were not interrupted, several of them reported a reduction in capacity of more than 50% of the services. And of course, it had a lot of repercussions. And in Ecuador, the number of maternal deaths increased by more than 20%. So the pandemic resulted in the deprioritization of certain health services, such as sexual reproductive health services, with impact of these on access to healthcare for women and people with diverse gender identities. I will stop here because I don't want to take too much time, and we can continue the discussion later.
Thank you, Manu. Thank you so much. Yeah, I think there's a term I heard from Brazil, the tyranny of the urgent, where everything else is just put behind and, emergency measures become prime rather than rights and needs of people. We now will move to Leah, our second speaker. And Leah, I have the same question for you. What are some of the challenges faced by women and marginalized groups in Africa? And how did the state respond to these challenges?
Thank you, Vanita. I will build on some of the analysis that Manu has already made in terms of thinking about historical and continuing inequalities for certain groups, particularly women and girls, sexually diverse persons, and basically people that exist farthest from the axis of privilege as a result of their gender, as a result of their caste, as a result of their race, and so on. One of the questions I was preoccupied with was the role of the state. Particularly, I was interested in understanding the state as a steward of marginalization, as a steward of distributing precariousness. And here I looked specifically at the legal and policy framework. So Manu talked about the criticality of recognition and the emerging marginalizations that comes from the state either guaranteeing rights or refusing to guarantee rights of certain groups, perhaps out of their moral stance regarding those groups, or perhaps as a result of that group's invisibilization just from being poor and not being seen as productive members of society. So some of the examples that Manu talks about were quite evident in the African context as well, based on how the state responded. Of course, all of us were overwhelmed by the pandemic. And if you're thinking about the African context, which had one of the highest disease burdens in the world, if you look at the 25 countries that were considered as having the highest disease burdens, Africa, 22 of them were African countries, riddled by HIV and AIDS and TB specifically. And then you're having the pandemic coming in that context. You're looking at a context that is weak generally economically, but also a context that had a very weak health system to begin with as a consequence of very little resourcing of the health system. So then what happens in such a context where there is a blanket response to the pandemic, and there is a tyranny of the urgent, and COVID is basically crowding out all the other health services and health emergencies? It means that those that are furthest, again, from the axis of power are the ones who suffer. So if we're looking at women and girls, for example, you're thinking Sex does not stop during pandemics. Pregnancies do not stop during pandemics. And it meant that those are health services that required attention regardless of the pandemic. For women who were pregnant specifically, they bore the brunt of blanket lockdown measures because they could not, number one, access antenatal services. Antenatal services are critical, of course, to ensure that mother and child, are healthy during that period. But in the African context, that is also the vehicle for accessing HIV testing to reduce mother to child transmission, which has been one of the ways in which we've dealt with the HIV pandemic. So it meant that that service as a whole got cut off. But for women that were needing emergency care in the middle of the night, many of them in Uganda, in Kenya, in other countries actually died as they were trying to access healthcare. Number one, because there was no transportation. Number two, because if there was any transport, people were scared of being caught in the snares of state violence, because if there were any motorcycle taxis, people would get beaten, people would get killed, and things like that. So that is something that that suffered. So it meant that women were giving birth outside of health facilities, and the complications related to that. For girls specifically, who access most of their sexual and reproductive health and rights services through schools, the closure of schools meant that that critical service was no longer available. So education is looked at as a sort of vaccine because of the ways in which it delays pregnancy, delays sexual debut, but also delays early marriages for girls. In the African context, that modicum of protection was completely wiped out. In some countries like Uganda, schools were closed for as long as 22 months. What are the consequences of that? Teenage pregnancies, early sexual debut, things of the like. And the very last thing, as I finish, I know that I've run out of time. I can't talk about the African context without talking about people living with HIV, and just how the pandemic prevented access to antiretroviral therapy, and therefore the consequences of that, which could be could mean that you have resistance to that medication because of interruption. You have higher incidences of transmission, and so on and so forth. And then if you look at the key populations who fall under that category, particularly sex workers, then those experiences were had significantly worse outcomes. So I'll stop here, but I hope that I'll speak more about those particular groups when I get another chance to respond. Thank you.
Yeah, thank you for bringing out these very critical issues where SRHR was considered non-essential, and the complete blindness of looking at the connection between education for girls and the pregnancy testing. We will have time for discussion later. Now, let me call upon Tasneem. And Tasneem, my question to you is the same. Can you highlight for Asia the challenges that women and marginalized groups faced and the state response?
Thank you, Vanita. Thank you, Dawn. And I'm glad to see that the many people have joined, and I hope we do have a very interactive session. The two speakers before me, Manu and Leah, they have really made all the key points. From South Asia, the region which I am representing, we had similar issues. The disparities in our society, the gender, caste, class, poverty, other forms of marginalization, such as migration, internal migration, which really had a huge role in our countries. We had issues where, migrants from the villages and smaller cities come to the larger cities, to the capitals, to work as daily laborers or whatever work they do, hard labor, domestic labor. They were forced, because of the lockdown measures and isolation measures, where people employing them also did not want people coming in, outsiders coming into their homes. They were forced to leave. They were jobless. And many started walking long distances back to their home. And as they were walking back, many died. And this lack of respect for people, lack of understanding that everyone needs services, everyone has a right to to safety, to food, to shelter. This was all forgotten. It became very individualistic. People started only taking care of themselves, and the state had a role in making sure that that was what was happening, completely forgetting the situation of people living in the margins. I will come back to that a little bit later, but what really, in South Asia, the big issue was the weak health systems. It's really weak here in all the countries that we see in our region. And with the pandemic coming in and the global policies that our national countries, that our nations adopted, we were forced to adopt these policies, not considering our local situation. And the weak health systems are really stretched. We could not cope. We do not have enough budget. We do not have enough human resources. We do not have equipment for testing. Lab facilities are weak. Hospitals, the ICUs, the oxygen supply, everything was stretched. And this was a huge burden for the country. It was for the service providers who did not have enough PPE. The nurses were getting PPE, the sizes of which were for men. So they had to wrap it around themselves to make themselves safe. So there's a huge gender gap even in the production of these, PPE, gloves, whatever you call it. And the demand was so huge, the supply just could not meet up with that. On the other hand, there's a privatization of health systems. The public health system could not meet up. So that we have in South Asia, a huge private healthcare system, which is, of course, very expensive. Not necessarily very good, but in many cases, they're better than the public health system. But who can afford that? Definitely not people living on the margins. They cannot. And the existing stigma against those people make it very difficult for them to access services. The stigma is so pervasive that healthcare providers do not consider themselves as human beings, can consider them as human beings. This also, part of the health systems is the weak data collection system. The data coming from our region was the surveillance system did not capture the epidemic fully. It took a long time. Certain parts of the region were better than others, but by and large, the data system for collections, the data collection system was extremely weak. And that really posed a problem because we didn't know what the issue was. We didn't know where the problems were. We didn't know where the shortages were. We didn't know how to act. This gap really should be a lesson learned, but I don't think we're learning any lessons. So coming back to the people living at the edges of the margins of society, I looked specifically at key populations that Leah was talking about, at female sex workers, at the LGBTIQ community, people who use or inject drugs. And what we found that these measures that were imposed on them, especially the lockdown and isolation measures, they are usually living in a community which is self-supporting. They support each other. And when they're isolated, that support system is lost. They not only lost their jobs for sex workers, they lost their clients. They became very, very poor. They got into this vicious cycle of taking debts and repaying debts at high rates. Total vicious cycle of poverty. So much depression, sorry, losing my voice. So much depression there were for the LGBTIQ community who usually do not live within their own families, who have rejected them because of their identity. They had to go back to those very families who were then violent towards them. The number of suicides that took place in Nepal alone, there were, I think, about 28 documented suicides amongst the MSM community. And we don't know how many have been undocumented. The huge, sorry, am I running out of time?
Stop you. Yeah.
Okay. All right. This is, we'll come
We
back
can
to all this
continue.
later.
Yeah,
Yes,
we
yes.
can
Okay.
continue.
Thank you.
Yeah. In the interest of time, I'm going to jump into our next question. In each of your regions, can you highlight some positive examples that emerged from your research and what do they teach us for the next pandemic? I'll start with Tasneem and move on to Manu and then Leah. So Tasneem, your chance again to speak.
Okay. I'd like to. I mean, we have some very good examples, I think, from our region. One, if we look from the standpoint of the state, and the other from the civil society movement. From the state, I'd really like to highlight the state of Kerala in India. Kerala did a brilliant job. You see, what has happened in Kerala is that the existing health system is very strong. They don't have a huge budget, but within that budget, they have a system which is from the top to the right to the village level, and they engage communities within their health system. They reach out to all people. And during the pandemic, they mobilized this system. They had strong surveillance. They could find out where the pockets of the outbreak were. They reached out to them. There was continuous clinical care provided, and the communities were engaged in providing food to those affected, in ensuring that their needs were met, in connecting with the clinical services. So Kerala is a great example, and which is a state example. Also in Bangladesh, we have a very successful expanded program for immunization, EPI as we call it. This is for childhood vaccination, and we have about 88% coverage of childhood vaccination. During the pandemic, when the COVID vaccines became available, this process, this whole system was utilized in distributing the vaccines, and it was very, very successful. Of course, there were many issues when we talk about our marginalized communities because of the stigma that they had to face. From the civil society perspective, I would like to really talk about what happened with female sex workers in India. There are two examples that I will bring up. One is from the Kolkata Shonagachi brothel, where we have a sex worker organization called the Durbar Mohila Samonnoy Committee. This has been active for decades. And this organization, then, because they're already there, they're a sex worker organization, they know what the problems are, they really mobilized. And they organized, collected, and distributed food for themselves and for other sex workers also. In Mysore, there is another sex worker organization called Asodhya Samiti. Now, this group already had linkages with the district hospital, and where the ARV centers are. And they have a link so that from the ARVs that were being given out to people living with HIV, the sex workers living with HIV, the sex worker organization was making sure that these were being distributed to the sex workers. So during the pandemic, this whole system was mobilized and used so that there was no interruption in treatment of sex workers living with HIV. So those are really good examples. And what it underscores, I feel, is that if we have existing strong health systems, those can be mobilized in cases of emergency, such as a pandemic. Instead of reacting to a pandemic, we need to have systems that are already strong and can be mobilized. That's my point of view. Thank you.
Thank you, Tasneem, for being right on time. Manu, how about some positive examples from your region in Latin America?
Sure. When we look into Latin America in terms of access to sexual and reproductive health services, so continue talking about this issue, there were some experiences of advancing the use of telemedicine, for instance, in Argentina and Colombia, but still there was great disparity between private and public services, urban and rural areas, and the need to expand the reach of online consultations and prescriptions and the logistics in terms of drug delivery and referral, especially within a context of shortage of healthcare professionals, mobility restrictions, and of course, unequal access to the internet. But we can also, in this context, highlight some of the protocols that were created. For instance, in Paraguay and Ecuador, focus on the interinstitutional coordination for a rapid response in case of gender-based violence against women and children during the health emergency period. There was also some experience of communication campaigns in Uruguay designed to reach out to adolescents about gender-based violence and to disseminate information about the services and hotlines available. So the positive examples that I would highlight, I mean, coming from the state would be more like particular actions rather than a positive example of a response, of a coordinated response, unfortunately. So what really stood out in terms of positive examples that teach us important lessons, not only thinking of a next pandemic, but as a response for the civilizatory crisis that we are living for, of course, a long time, are the main examples of solidarity and support networks led by communities, like Tanzania has also mentioned that has happened in the region. Women's collectives, indigenous populations, trans-led groups, they resisted the lack of effective policies through solidarity, promoting food security, disseminating accessible information about the pandemic in a way that is adapted to the realities of the neglected population, which was very important, especially in a context of dissemination of fake news. So in Brazil, for instance, the Women's Forum of Pernambuco, which is a social a movement led by feminist women, they created informative and educational materials, such as there is a manual that I think it's very interesting, like the Economic Hygiene Manual, how to prevent COVID-19 with little water and little money. Because we are listen all the time to the idea that we had to wash our hands and we had to wash everything. There are a lot of communities here that don't have access to water in their homes. So there was those groups that were talking to their realities, not just sending like universal message that was not resonating to their realities and that was impossible to commit. So they used social media, community radio to disseminate information that people could trust, that would help protect people in precarious situations. At the same time, they were highlighting that the problems related to the lack of democratization and access to public service. So what those experiences teach us is that we don't have to reinvent the wheel to find the responses. The responses are there in the communities now, in the experience of lived by women, migrant people, LGBTQI communities, young people, elderly people, indigenous and traditional communities. What we're missing is that the policies need to be built with the communities. Listen, learning, recognizing the knowledge, the wisdom, the technologies and the rights that are there in the communities, and that the rights are not commodities and need to be guaranteed. So we can build other forms of living based on solidarity, on mutual care, far from getting back to normal as we use it to say or to hear during the pandemic context.
Thank you. Thank you, Manu. That was before time. Excellent. Leah, so can you put the spotlight on Africa and speak about what are some of the positive examples that you can share with us?
Yeah, I want to start off by highlighting people power, just to complement Manu's last point. Just the importance of a vibrant civil society, number one, because of the role it plays in holding the government's feet to the fire. And number two, the role it plays in being a thinking partner and a planning partner for the state, because civil society organizations and social movements represent where people are located. So they're able to express and share lived experiences that can help the state better shape their responses to any crisis, not beyond pandemics. When we think about the Ugandan context specifically, which everybody on this call may understand as incredibly homophobic in terms of its legislation, and thinking about how queer people were caught in the snares of the state response, some of the things that actually happened were, in terms of vaccine rollout, it was actually queer organizations, LGBTI institutions that provided complementary services or some sort of education and access to vaccines for queer people that live in the shadows. I'm going to talk about that in my next point, which was a case of strategic litigation brought by a civil society organization against the government of Uganda because they mandated a national ID as a condition for access to COVID-19 vaccines. Now, for the average person, national IDs may not necessarily be a problem. But for queer persons for whom national IDs and the bureaucracies that they invite basically also invite onto oneself state violence. You know, the process of acquiring a national ID in the Ugandan context means that, you know, maybe you're going to have to go to family members, or you go to have to go to local council officials, and all of that entire process is violent. So most people do not have national IDs. So if you're requiring that people have a national ID to access vaccines, it means that automatically that group is excluded. But also just a large swathe of Ugandans who are poor, who just do not have time to go and get vaccines. So the state was sued, and that policy was removed immediately. Another example comes from Zimbabwe, where the state was sued for not providing COVID-19 information in accessible formats for people with disabilities. You know, so you're having all these processes. You're not providing them in Braille. You're not providing any kind of interpretation, and that resulted in the state, in civil society organizations suing the state. So just wanted to highlight that form of people power. In terms of things that some countries did well, you know, we have an example of Rwanda. So Rwanda is famous for having a very decentralized health systems. So unlike some countries that have like a couple of referral hospitals that are centrally located, most times in capital cities, Rwanda has a very community-based health system, which meant that when hospitals, large hospitals particularly, got overwhelmed, which happened in most cases, that was not necessarily the case for them, because hospitals were much closer to the community. But also what this did then was that at the point of distribution of vaccines, then it created a better coordinated process and structure for doing door-to-door vaccination. And then the last example that I'll give comes from Zambia, where they thought about what are some of the ways that we can reduce disruptions and how we can manage existing disease burdens, particularly around HIV. So for people living with HIV, like I mentioned earlier, access to antiretroviral therapy was interrupted. What Zambia did was to extend how much medicine was available for people that were taking antiretroviral therapy, and increasing the refills to 6 months instead of 3 months, which meant that you did not have to go to the hospital as much, because some people were staying away. They were self-isolating because they were afraid of catching COVID. Some of them were afraid of being caught up in the violence that lockdowns brought, and so on and so forth. So that example from Zambia, but another great example from good practice from Rwanda was that they actually did not change their policies in relation to antenatal services. Those are things that continued uninterrupted, and again, very much related to having a very decentralized community health system that enabled people to access health in spite of a global pandemic.
Great. I must say, I have to congratulate each one of you for more than keeping to time. So now we come to our very last question, and that is on the policy response. So what are some of the policy responses, reforms, and innovations needed in our health systems to address discrimination and exclusion of marginalized groups, and what are some of the ways to achieve them? Now, going forward, for each of your regions, what are the 3 key suggestions to deal with the next pandemic? Leah, will start with you. And you have 6 or 7 minutes for this. So this is a much longer discussion we can have.
Okay, all right. So when I was, in responding to this question, I must go back to the point that I made at the beginning of my presentation, which is about the role of the state as a steward of marginalization and as a distributor of precariousness. And there I talked about legal and social recognition and how this might have guaranteed rights for some or withheld, not only withheld rights from certain groups, but actually put them in the direct path of the onslaught of the pandemic. Some of my colleagues have talked about sex workers, we've talked about poor people, we've talked about, poor people as in economically disenfranchised people, we talked about LGBTI persons and people with disabilities. In order to be able to respond to a crisis, first you must agree within your legal and policy framework that people are people. And some of the existing policy frameworks do not do that. Actually, what they do is withhold those rights and criminalize certain groups. So basically what they do is produce a criminal identity. I was looking at this specifically in considering sex workers and how they navigated the pandemic, and also looking at LGBTI persons. My research showed that these groups particularly lived in extra-legal spaces. And by that, I mean that number one, even before the pandemic, these were criminalized groups. But also when we think about the public health mandates that were instituted by the state, which, as Manu talked about, she talked about a state of exception that is created, because it means that you're basically suspending civil liberties, such that if somebody comes and finds you walking about past curfew meant that you're not supposed to be, it meant that they could do whatever they do to, they want to you, and there is no recourse for that. So as a sex worker who plies their trade at night, basically after curfew, it means that your rights, if they existed at all, are further eroded. What we're seeing is sex workers negotiating power around condom use incredibly eroded. Sex workers' power in terms of even negotiating their rates incredibly eroded. Number one, because they're now desperate. So they'll take whatever they can have. We see experiences in Kenya where people are talking about this phenomenon of corona babies, where sex workers are having children that they do not want to have because they've had unprotected sex, where sex workers are so desperate to put some food on their table, on the table of their on the plates of their children, that they have services at 5 cents US dollars. Like that's the rate that, and that's because this phenomenon has been created where they absolutely have no rights. But that is linked to this criminal identity that has been created, and this is the same thing that happened for queer persons, because it already creates this economic disenfranchisement that is related to one's social identity. So what I basically described this as the state exercising its necro power. So then we're saying that you could not have a pandemic that is inclusive and responsive to the needs of people on the margins when those people are criminalized. So you need to recognize them in your laws. And by recognizing them, you're saying these people have the right to have rights, and they have to enjoy the right to enjoy rights just like everybody else. But there can also be a downside to legal and social recognition. Sometimes that recognition can be very paternalistic. And by paternalistic, I mean that it can say, oh, these are vulnerable groups and we need to protect them. And that can actually end up being an impediment, as happens with adolescent girls. So you'll find something very interesting when you're thinking about key populations. So key populations typically thought of as sex workers, LGBTI, men who have sex with men, people in prisons. They're thought of as key populations primarily because they have a higher incidence of HIV infection. But what is curious about this group is that adolescent girls are not included under key populations. And yet I insist they must. Why? If I give you a statistic from Africa, in 2022 alone, out of the new HIV infections, when you look at the demographic of 15 to 24-year-old girls. 77% of new infections in 2022 alone, 77% of them could be were attributed to adolescent girls and young women. If you look at it globally, out of the 44,000 new HIV infections that happen every 2 weeks, 3,100 of those are in Africa alone. Out of 4,000, more than 3,000 Africa. Why are adolescent girls and young women not considered key populations in spite of their high incidences of HIV transmission? Well, my hypothesis is that the law recognizes this group as marginalized, but it seeks to protect them, but bases that protection on a moral stance around adolescent girls' sexuality. So governments do not want to acknowledge that adolescent girls and young women are having sex. And so then, even when policies, there are all these demands for comprehensive sexuality education, for access to contraceptives and condoms for young women and I mean, for adolescent girls and young women, all those efforts in most African countries have been thwarted because of, that moral stance that I talked about. So by refusing to acknowledge adolescent girls and young women's sexuality, they're actually left unprotected instead, to be ravaged by HIV and unwanted pregnancies. And all of this was then exacerbated by the onset of COVID. I know I'm out of time, but I must make this final point. Sorry, Vanita. Yeah. And the final point that I want to make, because the other one was about the criticality of legal and social recognition. And then the second one I want to make is around what my colleagues have also talked about, which is financing, resourcing health systems. So one thing that you might have heard a lot about was just the low incidence of infection and death in the African context, in spite of our very, very weak health system. But what you might not have heard about is the outsized or the disproportionate number of deaths in Africa for those requiring critical care. So while deaths in the African context were low, for anybody who needed a ventilator, who was in a high dependency unit, who was in the ICU, the chances of that person coming out alive was very low. And that is because of the very low resourcing of the health system generally, but also really, really low resourcing for critical care. So when you look at just the distribution of ICU services in the African context, very, very low. And then in places where ICUs were then available, the cost of access was simply unaffordable. You had incidences where people were being required to pay as much as $1,000 to $2,000 per day in an ICU, in a context where people make $300 per month. It basically meant that was a death sentence. So that is something that we need to think about critically. And we also need to think about it when we think about the geopolitical context now, where official development assistance is decreasing. We have to think about it now where USAID, that's what we are all talking about right now, where that money is conditional and it has now been pulled away. And who are the people who are going to be in the front of the onslaught or who are going to bear the burden of that cut in funding? Again, it will be marginalized people. So resourcing our health systems, we need to think about where else to get the money for that. Thank you.
Excellent points, Leah. And I'm so happy you brought out how some of the challenges of the post-aid world that we're going to get into. We'll come back to some of these issues later, but let me call upon Tasneem now to speak about, the policy responses, reforms, innovations to address the discriminations of groups, and what are the ways, and what in the South Asia region, what are the key suggestions that you can give to deal with the next pandemic?
Thanks, Vanita. I will there are very important points that Leah has mentioned, and I will touch on those as well. But mainly we know that what happened in South Asia, and I'm sure that's true for the whole world, is that there were global policies that were formed, that WHO's global policies, which are really done by experts from the North usually, dominated by the North and really dominated by men. These policies were formed, and then they came down to the countries with the guidelines, and the local context was never taken into account. The national policies just adopted the global policies, not taking into account the contextual issues, let alone the marginalized populations. So therefore, if we talk about health for all, which is our mantra for public health, then this system will just not work. We have to know our global context. We have to our local context. We have to develop our own national policies and own national guidelines based on our context. But our context is not uniform. It's not a homogeneous. Any country is not homogeneous. We have various groups of people, the marginalized people, as we were talking about, marginalized groups of people. So if our policies do not include sex workers or LGBTIQ community into what their needs are, how will we understand what services are to be provided? What are their issues? The whole issue around stigmatization, criminalization, how do we deal with those issues? If they are not on the table at the very outset, we are not going to be able to provide a system that looks after everyone in society. So we have to, I mean, one of my worries is that we are still we look to the North, which is where our policies come from. We have to stand on our own feet. And that we've seen examples from our regions that there are good examples that we can adopt. And I really second Leah in the issue of criminalization and whether we can legalize and address some of these issues, because the stigma is so prevalent that no matter what policies we take, the stigma is so internalized that providing those services, even if we have it in our systems, in our papers, in our documents, might be very difficult on the field, in the ground. So we have to really work on this in a very, it's a long-term effort, and we need to work on it from the very beginning. So you were asking for three main policy issues that would help our region based on, let's say, based on our own experience. So I would say, yes, we need to address the weak health system without question. And given the situation, the financial situation at present, with less donor money coming in, fewer funders from the North, but we've seen an example from Kerala that even if when you do not have a huge budget, you can do things, and you can design your primary healthcare system so that it reaches different groups of people, different people in the villages, people in the cities, and make it more egalitarian. So there are examples that work, and we can look towards those and learn from those. And this is the responsibility of the state. We really have to, and our responsibility too as civil society members, to highlight these issues, to constantly talk about these issues, to bring these factors in so that policies are adapted accordingly. And not just, states that are doing it. We have civil society organizations that have done it. Again, I've given those examples. If we can do that in our country in smaller groups, why don't we bring them in systematically into the whole, government and civil society partnership, whatever we call it, so that we all work together and, make sure that nothing is done about us without us, only if we can work in partnership with all the different groups. And my third point would be that let's bolster South-to-South collaboration. There is a lot of, we've just heard from Leah, the examples that you've given from Rwanda. It's, they're excellent examples, what we have from Kerala, what we have from sex worker movements in India. and other places as well. Latin America has some wonderful examples. We can learn from each other, and let us learn and adopt these policies from each other. And at CSW69, there's been a lot of discussion how we can strategize, how we can all come together, the like-minded allies from, especially from the South, and, bolster our own, positive feelings, strengths, and see how we can influence our own governments in that way. Thank you, Vinita.
Thank you, Tasneem. So, Manu,
Sure.
why don't you go now to give us
Yeah.
a sense of Latin America?
Yeah, it's interesting because as both Leah and Tasni had mentioned, there is a lot of similarity among our region, despite being very different regions, but it says a lot about the global power relations and how it is directly connected to how the health systems and the blocking the right to health to all people is connected to this world system of power. So maybe I'm not bringing anything, I mean, new or very different, but if I'm thinking about three key suggestions, I would definitely, emphasize that investments in public health systems has been definitely one of them, because they're crucial to strengthen the capacities to maintain continuity of health services delivered during times of sanitary crisis. So it's essential to highlight, I agree with the role of the states as guarantors of the human right to health, both to reinforce their obligation to guarantee the necessary conditions of protection and collective care, as opposed to the approaches that individualize the responsibility for people's own health, and to demand transparent, responsible, and sustainable responses that go beyond the medicalized approach only. So I would definitely reinforce the need to fund health systems, public health systems, universal, free for all people in all of our countries. Is definitely a need if you want to have, a strong response to a different scenario in potential future pandemics. And having a public and well-funded health system is crucial, but we also need, and that I also have to agree with my colleagues, to remove, legal and social barriers that impede marginalized populations of accessing healthcare and social protection services, including, in the case of Latin America, promoting legal recognition of gender identity of trans and gender diverse people. This is still a struggle to be implemented, and during the pandemic we saw it clearly how not having gender identity recognition legally, it is a concrete barrier for people accessing health services. The same happened to migrant and refugee people. So we need the legal recognition and access to documents as a way of facilitating the access to healthcare services and social protection policies, and to prevent situations of institutional violence from the state itself, and particularly in times of sanitary crisis. Also ensuring public health information and communication is available and accessible, including for those with limited access to technology in rural and remote areas, and establish helplines. This is something that has worked to some extent, or spend helplines to inform about sexual and reproductive health services and for reporting gender-based violence. And also the need for trained professionals and welcoming environments free of judgment and committed to the right to health for all. I really feel like we need to reinforce, to kind of recover the idea of health as a right and not as a commodity, and it really needs to be reinforced, taking the risk of being repetitive here. But for creating those healthcare services free of violence, we will need to improve the mechanism of dialogue and consultation with civil society organizations, with communities at the national level, but also at the local level, to advance the elaboration of adequate public policies and services. We have seen, I guess, that in all of our examples, that the same happened in Latin America, that community participation, not only during health crises, but in a permanent and coordinated way, is an essential part of strengthened health systems and building effective responses. So having these health responses grounded on community engagement are crucial to guarantee solutions that take into account the lived realities of marginalized population and do not reproduce the previously established inequalities.
Thank you. So we come to the end of the question and answers from the speakers, and we're encouraging the participants to raise questions, but there are one or two questions that have come. And I think there's a question for each one of you. So maybe I will start with Leah. As a political economist, given the current challenging context, can you share some thoughts and insights on the ways in which some African countries with heavy debt burdens and austerity measures can work out ways to address the challenges of access to healthcare? Leah.
Vanessa, do you want to read all the questions just to give me a minute to respond well?
Sure.
Yeah.
So the three questions, and I can direct them to three of you. So you got your question, right, Leah? Yeah. So
Yes.
to Manu, you mentioned extreme inequalities in Brazil, but the country has a kind of a universal healthcare system. Can you share with us some of the ways in which this worked during the pandemic in the context of inequalities? And to Tasneem, in our limited knowledge, Bangladesh is seen as a donor-dependent country. How does the recent cuts in funding affect the country, and any thoughts on the ways in which the country can deal with this, and what are some of the strategies in a context where there's a new government and there are many challenges? How do you plan to deal with it? So I think some larger issues are being raised here. So for Leah, it's talking about the political economy, how one can, what are some of your thoughts on African countries with heavy debt burdens and austerity measures that actually happened because of COVID and the Bretton Woods institution loans and handouts? And how do you, in this, look, our research happened every day almost, we have a new challenge globally, okay? And this whole cuts in USAID, the whole rising right of the right wing, populist governments, and a bunch of other things that have happened, which I don't have to elaborate, have really shifted a lot under our ground. And I think we are in a stage where still grappling and trying to find ways and means to cope with it, not just as activists, but also thinking of some of our former ways of thinking. I mean, look at rights, look at UN, look at what's happening, you know? I mean, the kinds of people that are chosen to go as UN mission members for CPD and CSW are completely from the right wing, who bring in all these conservative ideas. Exactly that, Leah, you were making a point that unless criminalization of these groups are dealt with, we really cannot talk of access. I mean, what are we talking about when a whole bunch of people are criminalized, they're not legal, they do not have rights as right as people and to exist with their rights. So, I mean, it's an extremely difficult world. So, to kind of recalibrate that to our context and to raise these questions is challenging. So, it'll be nice to hear some of your thoughts as a political economist, Leah, and to see whatever. I think it has to be qualified statements, something that we need to reflect about. But I think it's important to have this conversation right now because Otherwise, most of our research is from the past where some things didn't change and are not changing now. But at least there were good examples, and there has been some, I mean, we have to look at some of the positive things that have happened. So I don't know,
Yeah,
anyone who wants to go first? Like Manu, you want to speak about the Brazil case and what happened and
sure,
how did inequalities work out for marginalized groups?
sure. We have in Brazil indeed a universal healthcare system. We call it SUS. Um, and but we had during the pandemic a very different government, a very ultra conservative government, the worst government that we could have it in all time. So despite we had this universal health system, which is well known not only for being universal, not only for all Brazilian citizens, but for foreign people, and for being very interconnected in terms of the national and state and municipal level. We had a national government which were working for making it not work, actually. So there was a lot of political dispute within the country between the national governments and the state governments and the local governments. So all of the pandemic was really was a thing that was really politicized. So and this was a thing for a lot of struggle, because Brazil had a structure for giving a response that was based at the community level, as it would be expected in a moment of containing epidemics. As we know, the community-based approaches would be much more appropriate, but it was not what happened in Brazil. So it is important that we had at some point, and we could have some response at some level, and it was very different from different states. For instance, the north of Brazil, in the region of Amazonas, it was a huge problem. A lot of people died. There are bodies on the street, and it was changing from states to states. So it really depended on the political perspective of the government, that if it was an ally or not an ally of the national governments. And this is something that has been discussed a lot, because we could have been using the structure of the communitarian agents for health, who are people who knows the community, who knows the people, who know their needs. But the health systems were being underfunded. Now we know that there was a delay in the negotiation of the vaccines, because it also could be used. Brazil has a good program of vaccines, but then we have the institution, but we didn't have the political actors moving ahead to making it work. So it was, as we know, Brazil is the second country in the world with number of deaths because of COVID, and many of them happened during the time. I mean, in the first 3 months of 2021, when we already had the vaccines, I mean, the world available, and we could have had that before. So, and of course, this is in terms of general, but when we look into the marginalized population, of course, it was part, as we know, it's a pity that this government of Brazil is also a part of this global ultra-conservative wave, and they were also very strong in blocking rights during this period. For instance, in terms of the case of the rights to abortion, they were forcing medical professionals to make pregnant people to hear the heartbeats of the fetus when they were going to consultations, as a way of make them like rethink their perspective. So there was a lot of these ultra-conservative wave blocking the well working of the structure that we have in Brazil.
Yeah, I think there's just a lesson that we can learn, since that is our theme for this event, is about having the right policies, the right programs, like a universal healthcare that we all clamor for as health activists. But if you have a conservative government at the center, then it completely skews the whole picture. So the whole importance of democracy as a principle, not just with elected governments, but as a principle, as something that we should aspire for, I think is a huge issue ahead of us. Because you can have the best policies, the laws, and uh, you know, but if you have not the right kind of governments, it has its limitations rather. Can I go to you, Leah?
Yeah,
Or
sure.
ready?
Yeah. This is a massive question that honestly deserves a whole webinar, maybe a whole class on its own about debt and austerity. But something very interesting that I encountered when I was writing this paper, because I also used the framework of necropolitics, again, to understand the ways in which the state withholds or gives rights or determines who gets to live or dies. And one of the authors that I encountered, South African, called Christopher J. Lee, talks about the state being so incapacitated because of our neoliberal economic systems that it actually no longer even has the capacity to guarantee life. The state can only be a steward of death. And that's the reason why, when we look at the COVID responses, most of them were violent, because that is the only thing that the state now still has the capacity to do, which is to protect private property and ensure control of populations, but not in any way that guarantees well-being. Now, how is that related to debt and austerity? I don't want to give a history lesson because we do not have the time for that. But even before the pandemic, when we're thinking about the African context, we have countries that were already incredibly burdened by their debt obligations, such that when you looked at national budgets, usually some of the greatest amount of resources were constantly going to debt servicing. And you can ask yourself, why is this the case? You know, it's a result of a global political economy where power is still largely held in global north and decided by the systems of the institutions of economic governance, such as the IMF and the World Bank. You have credit ratings agencies that downvote African countries such that acquiring debt is very expensive. You have debt that is denominated in US dollars such that paying it back is a tall order. But then a very critical question to then ask is that, so even when the debt is acquired, what is the debt used for? When you look at some of our countries, you have governments getting into partnerships with private entities, with public-private partnerships as a vehicle to make healthcare available, which basically means that governments are getting money in trust on behalf of their citizens to guarantee them health, but still that health has to be paid for because the partnership now has a private entity that has a for-profit motive, which is not what the state has. So then that ends up frustrating that goal of acquiring health, of guaranteeing access to health. And what is then interesting is that in quite a number of contexts, you'll go and you'll find shiny new hospitals with shiny equipment, but with no staff. with staff who don't know how to operate this equipment. If you actually look at some of the investments from the IFC, which is the arm of the World Bank that provides loan facilities for some of these healthcare facilities. My co-author, Komusana Sunshine, who's on this call, did this really great research looking at how medical equipment was being acquired on behalf of Kenyans, and this medical equipment was basically just gathering dust. All of that is part and parcel of the debt architecture. But also, if you think about what these institutions of economic governance how they were responding in the middle of a pandemic to countries that were in dire need, countries that were saying we need to purchase PPE, countries that were saying we need to purchase vaccines, they were still giving them grants, if they were given grants at all, with conditionalities. And those were conditionalities that were still tied to austerity, saying we're giving you this money, but we need you to decrease your government spending. That is an illogical response. That is a contradictory response. And that is constantly what African countries are hearing, not just in terms of health, but in terms of any kind of social investment that guarantees well-being for people. So this is not even just a health conversation. It's a conversation about transforming the entire global economic architecture that goes beyond my capacity, so sorry, as a political economist, to be able to analyze. But I'm just saying that there's so many levers that need to be transformed in order for us to have a health system that works for us. But for the African context specifically, it means that there has to be some deliberate political will to unyoke ourselves from these economic systems that actually subordinate and continue to exploit us. But we also have to have a tough talking our own governments, because we can talk about the structure itself, but our governments are also in bed and are beneficiaries of the corruption and beneficiaries of these corrupt systems as well. And to say that if we have even limited resources, what do we do with those resources? As Tasnim gave a great example from Kerala, that even with limited resources, if you have the right political will, a lot can be done. I know that does not really respond to the question. It really just raises other questions and maybe raises despair. But I think I'm just saying that there is a lot of thinking and action that needs to go into that. Thank you.
I think, Leah, it's so important to raise questions, even if we do not have the answers. I think this is something to really trigger us to think a little more deeply. And yes, it is very despairing even at this time, but surely, there is going to be resistance, I think, given that the way the world is poised now with the North and North against each other, we're going to watch something new emerge, hopefully. So Tasneem, we have to come back to you, to Bangladesh, and how does the recent cuts affect the country, and any thoughts in which how Bangladesh is going to go forward, just as an example?
Yeah, it's a difficult one, isn't it? I mean, we're all facing these cuts, and one of the biggest issues around the USAID cut is the cut on TB services, TB treatment. Now, this is something that's going to come back to the whole world. If we cannot control TB in our regions, and TB is huge in all our regions, in Africa and in Asia, it's going to affect, it will have a global effect. So it'll bite everyone. So what can Bangladesh do at this moment? As you all know, we are all struggling with the huge corruption, the debt that was left behind, the whole siphoning off of money that was done by the previous government, and how we're now really in a crisis situation in that way. But I have to laud the interim government in the sense the finance advisor and the governor of the Bank of Bangladesh have really tried to rein in this corruption. And they have actually they have managed to, repay some of the debts that we already had. And they're trying to rein in the banks, the corrupt banks, the people who were part of that money laundering issue. But on top of this cut is really going to have a drain on us. We're aware of it. How do we tackle this? I think this is a very, very difficult one. I'm not an economist. I don't have the answers, but I have faith. I have faith in our interim government because I believe they're honest people and I believe they're really trying hard. Because for the first time, this is the month of Ramzan where prices of essentials really go up. The first time we have seen that the prices of food and other essential items are actually lower than what they were last year. So that is either the same or lower. They haven't gone higher. So we have some hope and faith that something is going to come out of this. It cannot be as bad as it was. It won't be. We will not have a famine, for instance. Will we have another epidemic? I don't know about that. But I really believe in looking at good models. We have Kerala as a brilliant example. Thailand has very good primary health system. So does Sri Lanka. And Sri Lanka is going through a lot itself. So we can always talk to each other, learn from each other, and see. Sometimes I feel, some of these aid money, they come with so much baggage. And, a lot of it just goes back to their own countries. Maybe it's a good thing. It'll take time, that it will help us to become self-reliant. And, that's a dream, but I hope that that will be possible. It'll be hard, no doubt. And again, I'm not an economist. I do not have experience with working with managing, big funds in the government level and so on. But I have hope and I have faith. So, and I believe in South-South collaboration. I think that's the way to go. Thank you.
Thank you. I think we really need to kind of wind this up with hope, but there is just another question that I noticed in the chat. And I think we have one here. Can I read out that question and maybe one of you can answer it, and maybe I'll direct it to Manu because it's first talking about Brazil. Hi, my name is Fernanda Loureiro and I have two questions for all speakers, if we have time. Thank you, Fernanda, for your question. In Brazil, pregnant and postpartum individuals were classified as quote unquote risk groups during the COVID pandemic. How are these individuals classified in other countries and regions? How could this quote unquote risk group label impact their reproductive experience? Manu, you want to go first? And if Leah and
Sure,
Tasneem?
maybe, yeah. I believe that Fernanda would love to hear from Tasneem and Leah also, because she might also know more about our region. And I would have to say that I don't know, I mean, looking into South American, how it was classified indeed in each of the countries, because in the research where I was focused more on which were the countries which recognizing sexual and reproductive health services as essential or not essential. But I think it's connected to what you are asking, because it's interesting to see how the pregnant person occupies a different space of women when it comes to those policies. And it's very interesting because when we see that some countries in South America, they just were against the recommendations of the WHO, like Chile. They didn't recognize any reproductive health service as essential during the pandemic. Other countries, they did recognize some services and not other services, and like Bolivia, Ecuador, and Peru. And in those countries, the services that were not recognized were exactly abortion services. And it is interesting because it has a lot to do with what rights are recognized to women when it comes to her body. When it's thinking of pregnant people, it is recognized, but when it comes to the right of abortion, it's not recognized. And so there is a lot of opposite directions in this sense in Latin America. But I guess, and I don't know if this is what you're interested, but when I see, at least in most of the definitions, I have this sense that when the pregnant people is considered as risk group, it is more in the perspective of maternal mortality. So I would say that's what I've seen, but it's more like general impressions of the regions than a very detailed information that I don't have from each country.
Thank you. Tasneem and Leah, would you like to add something? And I think the key point is what you made, Manu, about what is recognized as essential services. Okay, and that decides. Yeah. So,
go on, Leah.
In my context, originally, pregnant women did not have any special designation. And as a consequence of that, as I illustrated earlier, quite a number of them died from pregnancy-related complications, either because, you know, they could not get transport in the middle of the night, or because services, you know, at hospitals had been rerouted to respond to COVID. But again, it goes back to the larger point that I made about what recognition or misrecognition within the law does, or the blindness to certain inequalities does to certain groups. All those women who died were not poor women. So there is the assumption that when we're dealing with a crisis, there will be pain, and of course, some people will die. But the calculus about who gets to die, it is not random. It is always those that have the least power, or rather those who have the least resources. So I am 100, maybe the state did not even think about this at all, that what about pregnant women? What if they needed to go to the hospital? So the thinking is that, but of course some will die, as is the case with maternal health anyway. Even outside a pandemic, there's always the thinking that some sacrifices will be made. And that's the reason why you're not funding the health system to begin with. But of course, a few will die. But then the people who get to live are usually the people that have access to those resources. So if you had a woman that was classed and maybe had connections to the state, you know, that person would be able to access health no matter what. But if you were a woman in a slum and nobody, as many of the women, and I use nobody in quotation marks, it meant that you basically had a death sentence. And that is what a blanket response to a pandemic meant for anyone who existed on the margins.
yeah. Tasneem?
In Bangladesh, again, reproductive health services were not prioritized. This is as far as I know. And I don't know, Vanita, what happened in India, but they were not a risk group as such. We had older people, people with comorbidities that were considered, and pregnant women were not in that list as far as I know. And, you know, we don't know, we don't have the data on how many pregnant, what morbidity or mortality was associated with pregnancy in COVID-19. We just do not have that data that we can give figures and numbers on what happened with women who were pregnant and delivering during that time. So Vanita, if you have something to add from India, it would be nice to hear.
So even in India, it was seen as a non-essential as much as even, you know, dialysis, cancer, and the rest of the comorbidities. So we also, except Kerala, they made it an essential, the state made it an essential, and they had excellent services for lots of antenatal checkups as well. So there were some states in India where we don't have any data. And, you know, one of the problems about data was that like in India, it's estimated that there are millions more who died because of COVID, but the death certificate will attribute it to a comorbidity like high blood pressure or heart or cancer or kidney failure or something like that. But it will never attribute it to COVID. And that there were some states where they deliberately avoided it, not to get a bad name. So that has been the issue. And I think for the next pandemic, one of the things is to really recognize the essential services, not just for comorbidities and these dire, terminal illnesses, but also for pregnancy, because, it's completely out of a woman's control when she delivers and when she does not. So, and like Leah said, those with resources, including power, could access private services. So that worked. Otherwise, it did not.
The other thing that I would really like to add here is that what was overlooked was mental health issues.
Yeah.
And with schools closing, with women being the domestic violence, and of course, marginalized populations, the violence they faced, the number of suicides that have gone up during and post, these really have had a major toll, and we need to consider these issues in future pandemics. They really have to be brought into the picture.
Yeah. I think we still have some 30 people, and thank you so much for being with us. And we have come to there are no more questions in the Q&A nor in the chat box, so we can bring this session to an end. I think there were many, many issues raised, and it's extremely difficult for me to kind of summarize them or have some concluding remarks. But I really want to end by saying that some of the things that our speakers spoke about and I think that makes sense, is to really begin to connect what's happening at the macro level. I think lots of points that Leah made with what's happening to marginalized populations, because they're highly connected. I mean, criminalization is such a powerful example of you can have the best universal healthcare system, but if you're not recognized, and then you're completely out of the system. So I think we really spoke about some good examples, and maybe I would like to leave this thinking of, that there is hope, there is a way to move forward, and let's really hope that some of you who are our audience will also take interest in the issue of access to health, access to medicines, and move on to really work on them in your own capacities in your own organizations. Thank you so much from Dawn, from all of us here, and from the comms team who is helping us to put this up, plus our secretariat staff in Fiji who work behind the scenes and do a great job of facilitating these events. Thank you again. Thanks a lot. Bye, everyone. Can the speakers just hang on a bit? Just for 5 minutes? Leda?